what actually EBUS is, or endobronchial ultrasound is, I can say only in one line that it is an epitome of innovation in interventional pulmonology. But before this instrument got invented, what was the need? Why this EBUS is the need of an hour in interventional pulmonology? Basically, it samples the lymph node. So let us start with very basic, what actually is a lymph and a lymph node. So lymph originates when blood plasma leaks out of capillaries into the interstitial space. And along with the normal macromolecules, it also has virus, bacteria, pathogens, as well as tumor cells. And this all gets captured by our immune cells through the lymphatics, and it gets deposited into the lymph node. So we all have lymph nodes, but once there is deposition of abnormal type of substances, whether there are infections, certain type of granulomatous diseases, or certain type of malignancies, then these lymph nodes get enlarged, and then it becomes very important to sample those lymph nodes. So when this lymphadenopathy, the term lymphadenopathy is when we all have lymph nodes in us, but when they are enlarged to more than 1 centimeter, then it is termed as lymphadenopathy. Now this lymphadenopathy happens in many areas of our body, whether it is neck, abdomen, and most importantly where EBUS works is chest, a part of chest called mediastinum. So mediastinum is, the word is derived from medieval Latin, from the midway, that is central component of the chest. So here we can see the center part of the chest, this outline with the blue shadow, is called middle mediastinum. So there are anterior, middle, and posterior mediastinum. In anterior and posterior mediastinum, usually the pathologies are addressed with the CT guided procedures. While in the middle mediastinum, because of high risk of inadvertent injuries to the critical organs like heart as well as great vessels of the body, they are not approached with the CT guided. That's why the EBUS comes and plays a big role. Now coming to the mediastinal lymph nodes, what is how they are classified? So this is an international classification that we can see above the clavicle. They are called highest mediastinal lymph node, that are supraclavicular lymph nodes. Then 2, 3, and 4, these are called as station, and these are tracheal, paratracheal. The station 2 is upper paratracheal, station 4 is lower paratracheal, and station 3 is peritracheal lymph node. Station 7 is subcarinal lymph node, and there are vascular nodes like station 5 and station 6. These are subaortic and para-aortic, and then there are paraesophageal lymph nodes. Now the lymph nodes with the stations in double digits, that is 10, 11, 12, 13, they all are segmental, lobar, and subsegmental lymph nodes. So in short, what we can assess with the EBUS is this all lymph nodes in the single as well as in the double digits. Double digits lymph nodes are only being sampled with the EBUS. That we'll see later. But what are the causes of this mediastinal lymphadenopathy? We can memorize it with a mnemonic called MAGIC. M stands for malignancy, that is the most common cause. A comes for allergic alveolitis as well as autoimmune diseases. G for granulomatous diseases like sarcoidosis, vectors granulomatosis. I for infection, most commonly it is tuberculosis as well as fungal pathologies. And C that are reactive lymph nodes associated with comorbid conditions like COPD, pulmonary hypertension, and else. So when there is referral to pulmonologist when there are mediastinal lymph nodes first, when the patient is having symptoms like persistent coughing, hemoptysis, or chest pain, then there is incidental finding on PET CT scan or a CT thorax. Many of patients, like when there was in COVID era, when all were undergoing CT thorax, we got so many incidental mediastinal lymphadenopathy. Then there is suspicion of tuberculosis, sarcoidosis, lung cancer, or lymphoma. And fourth is for the staging of the lung cancer. Once we need to decide whether this patient is will be benefited with the surgery or not. So coming to case number 1, she was 51 years old female housewife, known hypertensive as well as gastritis. She was diagnosed as having neuroendocrine tumor involving pancreas. For that, she underwent Whipple's surgery in August 2022. She was only on conservative treatment, and incidentally, on whole body PET scan, she was found out to have PET positive mediastinal lymph node, right paratracheal lymph node of 2.3 into 1.5 centimeter with SU index of 4.4. Now, what does that mean? It means it is an active pathology, and there was another lymph node which was subcarinal node or called station 7 node, 2.1 centimeter to 1.2 centimeter with SU index bit less, 3.3 centimeters, and she was absolutely asymptomatic. And then she was referred for the further evaluation. So here we can see CT scan. This I'll just give a brief tour about how to interpret this slide. So this black parts are lung. This is right lung. This is left lung. This structure is aorta. This is ascending aorta, descending aorta, and this is pulmonary artery, this is SVC, and where we are seeing lymph node here, it is beautifully getting lit up in the PET scan, as you can see. So as you can see, this is middle mediastinum. There are great vessels, and the pathology is here. Now the patient is asymptomatic, but we need to identify certain questions, whether this is recurrence of a NET, whether it is metastasis, or whether it is new pathology. And for that, we need to have sampling. So what are the conventional options till now, before EBUS? We can consider surgical approaches like mediastinoscopy, where we need to put incisions. The procedure is done in general anesthesia, or we can do VATS. VATS was usually done for the double station lymph nodes. But the thing is that they are making very much invasive, and it is hardly convincing to the patient, for asymptomatic patient particularly, to undergo this surgery, which is also costly. The second option is conventional or blind bronchoscopy. As we all know, we can do sampling of a mediastinal lymph node with conventional bronchoscopy, but then it is a blind procedure. The limitation is that it has limited access only to station 7, and it has less seal because we are not sure where we are puncturing, whether we are going inside the lymph node or not. And then there is obvious risk of inadvertent injury to the great vessels because we don't know where we are heading with the needle. So there comes the role of endobronchial ultrasound. What it is a diagnostic modality in which a miniature ultrasound transducer is introduced into the tracheobronchial lumen to provide sonographic images of a peribronchial tissue. That is like ultrasound from within, like a transesophageal echo, or like esophageal or endoscopic ultrasound. It visualizes a structure which are not visible in the conventional bronchoscopic view. So it is available as radial probe as well as linear probe. What we have at EPIC is linear probe EBUS, where we have real-time guidance of sampling mediastinal lymphadenopathy. And it has become now a standard of care to use EBUS to sample the mediastinal lymph nodes. Then why not esophageal ultrasound in this case? As we can share the same principle. Like this is a very good map which shows the areas which can be sampled by the EBUS and which can be sampled by the esophageal or endoscopic ultrasound. We call it EUS. So red ones, these are solely being sampled by the EBUS. This striped one solely being sampled by EUS. And here there are certain black lymph nodes, black color lymph nodes, which can be sampled by both. So here, in our case, we are going to sample station 4R lymph node because that's where the SU max is high, and that is also a bigger node. Here we can see station 4R can be sampled by both EBUS as well as EUS. But when you see here, when you compare this, the location is such, this is esophagus and this is trachea. So it makes more sense rather than sampling from EUS, from esophageal, to go here and taking more risk. It makes logically more sense to sample it from the tracheal lumen so that we can decrease the risk of inadvertent injury to the vessels. And hence, what is the equipment looks like? So it's a linear CT EBUS, it is a flexible bronchoscope, it can pass through nose or mouth, passes through the vocal cord, enters into tracheobronchial. So there is no incisions involved. It goes through the natural orifices of the body, and it allows simultaneous and real-time display of two images, bronchoscopic as well as ultrasound image. And then the ultrasound transducer has a tip of 7.5 megahertz probe, and it can have a depth of around 9 centimeters. So this is what the scope looks like. This is an ultrasound transducer, and here there is a camera which can give us endoscopic image. And this is how it works, that once we pass through the trachea, and then we have ultrasound image, EBUS, endobronchial ultrasound image, we can visualize the lymph node, and in real time, we can get the sampling. So again, this is the trachea, these are the lymph nodes, and this is an EBUS scope which is going inside the tracheal lumen and can visualize. We have the image on our sonographic processor, and in real time, we can puncture the lymph node and get a good sample. So how do we do the sampling? There is a dedicated needle called EBUS needles. There are many variety of these needles, and each has their own pros and cons, which is beyond the scope of this lecture. So here you can see this is the working channel from which the needle passes, needle comes out, and it punches the lymph node, and we get the sample. This is a good regional map which shows which type of where do we have to puncture in different stations. So it also gives an advantage to study the characteristics of lymph node, which is not available through CT or MRI or even PET. That is, we can study the size, shape, margins. Then echogenicity about central halo structures as well as coagulation necrosis sign, which gives us pretest probability of what we are actually thinking in this case. The other advantage is assessment of the vascularity and to choose the specific area which none of the other modalities gives. And hence we can particularly target the part of the lymph node which is less vascular to avoid bloody smears. So now coming to our case, this is our case where we had this lymph node. We need to puncture. This is right main bronchus, left main bronchus, and this is bifurcation called carina. So we needed to puncture here. We could see here station 4 where there is SVC line there. And then we are puncturing with the real time. So this is how we did the sampling. This is a short procedural video. So as you can see, there is a blood vessel here. This is a lymph node. These are blood vessels within the lymph node. And here, this is the needle which is puncturing, and now we are taking the sample. As you can see, there is to and fro movement of the needle. This is beautifully seen, and real time we can guide this. We can aspirate and then we can study what is there in the lymph node. So coming to our case, we did EBUS TB from this station 4 lymph node, and the gene expert was positive. It was rifampicin. Rifampicin was not detected. Histopathology showed cases reticulocyte inflammation, and we started on food acidity. The patient as such was asymptomatic, but patient gained at least 4 kg weight, and she completed the regimen successfully, and repeat surveillance is still awaited. Coming to one more case, where there is real-time guidance, it was station 7 or subcarinal lymph node. Now the thing is with conventional bronchoscopy, when we have put the needle, we don't know where the needle is going. As you can see, this is a big lymph node, but our needle is not puncturing it. And here you can see with the real-time guidance, now we can align and adjust the needle, and now we can see beautifully that it is puncturing the lymph node. We can also see that there is a blood vessel here, and it is not going or piercing in the blood vessel. So it gives us precise, it gives us so much precision, and it avoids risk to the inadvertent picture of the great vessels. Coming to another part where there was again station 7 or subcarinal lymphadenopathy, and we can see a big vessel passing through or intranodal vessel which was traversing the station 7 lymph node. However, when we did EBUS, this is a point from where the needle will come. And here there are big shadows of color Doppler positivity, which means these are blood vessels which are coming in the path. So we immediately converted to the esophageal ultrasound or endoscopic ultrasound, and we went through the esophageal route, and we get the diagnosis of sarcoidosis in this case. So this is how the combined approach works. In short, EBUS TBNA has many advantages, like it has sampling with the real-time images. There are no incisions in front. It is minimally invasive and it has high yield. In EPIC, we usually do this procedure as a day care, so there is no hospitalization also. Coming to the part why we need to prefer at EPIC, because first we have so many variety of needles. So if one needle is not getting acid, we can use another needle. Second, we have availability of rows which very few centers in Ahmedabad are giving, and which can decrease the procedure time, like the test, like the EBUS which we did last week, where we could just conclude the procedure with just 2 passes, where actually we have to go 4 to 6 passes if there is no availability of rows. In that manner, we can decrease our time. And third, there is single endoscopic suite for EBUS as well as EBUS. The same procedure is, so same processor is used. So that's why if anything happens, we can just convert to another route without any additional cost to the patient. So coming to the yield, it's meta-analysis about EBUS yield in tuberculosis. Around 80% of cases we can good identify with the EBUS. The sensitivity is 72.6 and specificity is 96.3. The combination of gene expert gives yield up to 96%. So we always do gene experts first when we are thinking that this can be tuberculous intestinal lymphadenopathy. Coming to sarcoidosis, sarcoidosis are a bit tough tissue, and hence the yield comes bit down to around 79%. And then in cases of lung cancer, it passes like with the flying colors. It has 84% sensitivity. It has replaced mediastinoscopy for lung cancer staging for that purpose only. And finally, lymphoma. Lymphoma are again very hard tissue, and we need good core biopsies. That's why TBNA gives less yield, around 66%, but it is still better. And the innovations are still in the paving the way, where we are getting bigger and bigger tissues and solving this problem. Finally, in other like metastasis from the another body part malignancy, the yield is around 78 to 79%. Again, the head-to-head comparison was done with the conventional or blind TBNA and EBUS TBNA. The yield was significantly higher with the EBUS TBNA because we get the real-time guidance, and hence EBUS TBNA is the standard of care. So finally, I conclude my talk with take-home messages. First, that EBUS TBNA is safe and high-yield procedure for diagnosis and evaluation of mediastinal lymphadenopathy. It has replaced mediastinoscopy for lung cancer staging, and by diagnosing condition-appropriate intervals to be cost-effective in long run. Thank you so much for your patient listening. Thank you so much for inviting me for this. If there are any questions, I'd like to take that.
Excellent presentation. Very nice. Very short and precise. I have two questions for you. One, what happens if you hit a major vessel? Being a vascular surgeon, the first thing that comes to my mind is, what if you hit the aorta or you hit some blood vessel, what happens? And second question is, how frequently can you do it? Suppose, for example, today you've done it and it's not been successful, or for some reason you could not get adequate yield. When can you next do the procedure?
Sir, I'd like to answer the first question.
Not the second?
Thank you. So, it is in theory we have always been cautious that we don't hit the great vessels. But then now the reports are coming, people are getting more and more adventurous. So the next station is called TVNA, that is transvascular needle access. As we have seen station 5 and 6, there are para-aortic and subaortic lymph nodes. People are doing even sampling through and through, passing through either pulmonary artery or through the aorta without any significant complications. So these are adventurous pathways, I would like to say. But in beginning of the program, we will not like to venture into that part. The only thing, we are not worried about the inadvertent puncture because none of the literature has found that as a major complication. We as a proceduralist, we are more concerned with the damage to the scope because when the needle is out, it can easily puncture the scope and damage the fiber optic bundle. So so your answer is that the risk is pretty less.
More than the patient to worry about the scope.
Exactly, sir. Exactly, sir. And now coming to the second part, as it has been told in many conferences that the first complication of EBUS is non-yielding procedure. So we need to focus more and more how to increase the yield. So I like to take this opportunity that we have done around 15 EBUS till the inception. And none of the procedure till now has failed to answer the clinical question. So we have found, like in this case, we have found an answer that it was tuberculosis. In other cases, we have found that there are malignancies. And in other cases, we have found that there is nothing, they are just reactive lymph nodes. Another part, there was a staging lymph node, which we have done beautifully. And we have answered the query that this patient can undergo surgery with the curative intent. So in our small study, we are still coming up with a large number of cases, but still around 95% of cases, I would like to say that we have answered the clinical question and our yield is that. So the 5% cases we just observe, we try to treat empirical treatment, and then we can definitely do the radiological imaging to see whether we are heading in a right way or not. If not, then we can repeat after 2 to 3 weeks. And if EBUS, after all, has not given it after trying through different needles, there are different sizes of needles. It's completely different topics, sir. Different needles, different way, and availability of rows, different techniques. So it's completely beyond discussion of this, but that is where the science lies. And we try to give the best of the yield. In my experience, if you are not getting yield with the EBUS here at EPIC, then the second station is you have to go for mediastinoscopy. So that, yes sir, Anuma sir.
Is it more important for anterosuperior aspect of mediastinum because that is earlier than the posterior inferior, because that
Yes, sir.
is what you are always looking for.
Yes,
isn't
sir.
it? Anterosuperior aspect.
Anterosuperior aspect.
So what about the infraposterior aspect?
EUS sir, endoscopic ultrasound.
And-
We go through the esophageal route.
And what are the incidents, like suppose spillage of the contents or mediastinitis or all these things?
So they are rare, sir. They are hardly been documented. I would like to say less than 1% of cases have mediastinitis, pericarditis. Particularly, there was one important case where there was a tuberculous lymphadenitis where there was coagulative necrosis, and then there is mediastinobronchial fistula after EBUS, but that's only a case removed because there was pus there, and they have removed the pus from that, so that was continuously coming.
Yes.
But it hit very beautifully after 3 weeks of antituberculous therapy. So there was a small risk of mediastinobronchial fistula
Yeah.
after getting TBUS.
Yeah, that's what my question. Issue.
So, but this is very rare, sir. Till now, we haven't seen any complications like major bleeding, mediastinitis, pericarditis, or any sort of fistula. The truth lies in selecting the proper area. There is another technique called fanning technique, which we use to increase the yield, and we try to move the needle in such a way to target the area where we have the best representation of the sample. Like in malignancy, this is core to core, that is subcapsular area, while in tuberculosis, there is center, but not the vessels. So we can easily adjust our needle with real-time guidance, and we can increase the yield without any complications.
So in out of 15 cases, like how many were malignancies, tuberculosis, like differentiations? Like?
Sir, 4 cases were malignant, 3 cases were tuberculous, and rest 7 were reactive mediastinal lymphadenopathy. One particular case I remember, because we don't have a robust radiological reporting like what we have at EPIC. One particular case I remember where the patient was sent to me for mediastinal lymphadenopathy, vague report of enlarged mediastinal lymph nodes, and on EBUS I was not able to find any enlarged mediastinal lymph node. Then I tried, and then I called help that I am not finding any lymphadenopathy, whether someone else all can also find. And then Kaushal sir came, and then we both searched, and we didn't find any mediastinal lymphadenopathy. So then it does happen that when there is infection, ultimately we can consider it like tonsils. Tonsils or lingular tonsils are also lymph nodes ultimately. So when we give antibiotics, they get subside. So when there is reactive lymphadenopathy, with the treatment of 7 to 10 days of antibiotics, they tend to get into normal shape. And that's what happened, that we stopped and we told the patient that there is nothing, that the patient came with hoarseness of voice, and the patient's hoarseness of voice also completely reversed within 3 weeks. So then we told that you don't need another intervention, no radiological interventions are also needed.
Very nice presentation.
Thank you so much, sir.